everyone, and welcome to this very special segment where we are celebrating outstanding achievements in the treatment of peripheral artery disease with the inaugural Global PAD Impact Awards. And today I'm excited to introduce the recipient of the USA Interventional Radiologist of the Year Award. Now, this award is all about recognizing a healthcare professional who has made a real difference in saving life and limb, as chosen by patients from the Global PAD Association's network, and of course, approved by his peers. To earn this award, this recipient has shown an incredible ability to go above and beyond in assisting our team in expediting care for patients with PAD. He has managed multiple times, in fact, to exhaust all efforts to save our patients' limbs, those who have critical limb ischemia, the advanced stage of PAD. Now, this individual has also proven in his capabilities to reduce the need, and this is very important, to reduce the need for repeated interventions by getting it right the first time and focusing on long-term patient care. This individual never rests upon his laurels, settling for it can't be done. He always tries to find a way, as he is always on the cutting edge with innovation part of his work. His peers even look to him for guidance on new strategies and technologies that truly push the boundaries of what's possible in PAD care. Now, even more, he is a team player ensuring comprehensive, interdisciplinary, holistic care for his patients. And he does it all while bringing empathy, that truly personalized patient-centric approach to every single patient, making sure that every patient feels heard and involved in their treatment decisions. So what do you say? You want to meet him? So without further ado, I am thrilled to announce that the USA Interventional Radiologist of the Year is, drumroll please, Dr. Mahmoud Razavi from Vascular and Interventional Specialists of Orange County in Southern California. So congratulations to Dr. Razavi. I'm so excited. Thank you for all you do for our patients and having such an incredible impact.
Well, thank you very much, Kim, for that kind introduction. I'm not sure I deserve it. Appreciate it, and it's a privilege.
Yeah, I think we should dive in and let everyone know if they don't know you. I know so many do know you, so many of your peers especially. Our patients certainly know you because you have been a very big topic of conversation of late. And with so many patients, whether they have come from us or not, they're in our network of 12,000 patients, and so many of them are talking about you and the extra effort that you provide for these patients. Now, if you look back on your career, as an interventional radiologist, number one, what made you want to become an interventional radiologist with so many different areas of practice? And then number two, with so many different areas within interventional radiology that you could have focused on, why PAD, and more specifically, advanced PAD? Because I know some interventional radiologists that do not perform advanced interventions for CLI patients. Why did you decide to go in this direction?
Well, back in the mid-90s when I was completing training, the field of image-guided therapy and minimally invasive treatment, ways to minimize surgery was just at its beginning, and interventional radiology was at the forefront. And so it was an exciting area. And so I was trained, at my fellowship in Stanford. At the time, it was the hub of minimally invasive aortic, arterial, and deep venous intervention. So I gravitated to the same. And later on, it just became the focus of research and my clinical activities. Of course, that field is just keeps evolving. And now they're into treatment of local regional treatment of cancer and what have you. But I have, because of my training experience and interest, have stayed focused on, some would call it plumbing of the body. arterial and venous interventions.
So many doctors, though, they don't want to learn the advanced methods. They might say, hey, I want to go into PAD. I like treating the legs. But as we know, few are learning those advanced methods. Maybe now more than ever they are, but it's really slow to go. Why are you committed to advance PAD care, particularly the focus on CLI, and really exhausting all efforts, going clear into that very critical pedal plantar loop to make sure the last mile is connected to a wound that won't heal?
I'm not sure if it's entirely due to lack of eagerness by all physicians to learn or practice the advanced techniques. The advanced techniques and strategies that we use to treat these patients with chronic limb-threatening ischemia or patients who have these advanced PAD, they develop over time and have a direct correlation to disease-specific device development and investment by industry and development of data behind it. So many physicians, wait until it becomes the standard of care and the data and instrumentation to mature. Some of us are at the forefront of that in participate in the clinical trials and the development and all of that. By the way, not all the approaches we take into these trials work, and that's the objective of doing it. So I think the issue is that most physicians who are in this space wait until the instrumentations, techniques, and data become mature and part of guidelines before they adopt it. And we've seen it in the treatment of iliac disease, superficial femoral disease, carotids, renals. Now it's the turn of below the knee, which is the sort of the ultimate, or below the ankle, as you mentioned, the ultimate holy grail of treatment of these patients.
I definitely understand that, for the majority of patients out there, that there needs to be that standard of care. And we have the 2024 guidelines that have come out that are using a level one evidence, to create those standards. But even the doctor that we talked to, Dr. Mehdi Shishabor, whom you're really familiar with, formerly of Cleveland Clinic and now at University Hospitals, he was part of the 2024 guidelines. And he says the most frustrating part of creating those guidelines is they take 2 to 3 years to create. And by the time that you actually release them, they're already old news because so much new evidence is being created along the way. And you're one of those that is on the cutting edge. But what's always frustrating for me in particular is when a doctor says that's not standard protocol to treat that patient in that way. It's not evidence-based. And I said, well, why aren't you part of the crew to actually create the new evidence? Medicine is still a practice. And that's why I think so many of our patients have so much respect for you, is because you don't rest on your laurels, that you are trying to push the limits to try and create new evidence with new tools, new techniques to help these patients have the best chance, or should I say, even better chance at saving their limbs and keeping their limbs just a little bit longer, right?
Absolutely. I mean, you touched on a very important issue, and that is the timing of guidelines and the literature and the actual research. They all, the practice usually should be, ahead of some of these features, but that doesn't always happen. And then the other issue that needs to be discussed, and we'll get a chance to touch on it, is the role of policymakers and the reimbursement specialists and the reimbursement by insurance companies and all of that, which entirely impact what we do. But Dr. Shishabor is absolutely correct that frequently guidelines are behind practice, and at least some of us who push the envelope.
Yeah. So I want to get back to you a little bit, and I want you to share from me 6 minutes that mattered in your career, some sort of defining moment, a catalyst for change, a spark that maybe led you in a specific direction. You know, it could be a conversation that you had with someone, it could be a scene from a movie you watched, some defining moment in your career.
You know, you said 6 minutes. That touches a nerve with me. And I mean, this is the first time you brought that up, and the reason is because, you know, there was a long time ago when, you know, there was a patient, and I recall a 16-year-old boy who came to us through the emergency room, and I went to meet him in the emergency room bed, and his father was standing next to him with his hand on his shoulder. And he had a condition called Ehlers-Danlos syndrome, which predisposes to catastrophic aortic disease. And he had what we call an aortic dissection that came in, acute aortic dissection, was bleeding from it. And he came into the emergency room, and he, when I went to see them to treat them, and these patients are now treated again, aortic disease also moved quite a bit, like critical limb ischemia patients, in the direction of minimally invasive treatments. And you know, it's a condition we've known, we've treated. It's in our toolbox. We have the instrumentation, everything. And he looked at me, the patient, and he said, "Am I going to die?" And you know, the question didn't sink in me because we've seen this before. It's part of our playbook. We know how to treat this. And I said, "No, we got you. You're not going to die. We'll take care of you." And 6 minutes later, he was dead. This is the sort of situation that sort of, you know, we're all have learned and have certain set of skills and knowledge that we practice in medicine, but it takes something like this to change you from a practitioner to a doctor. And I can't tell you the impact of that. That now every patient we talk to, whether it's minor or major, one has to be careful when we talk to them. And that completely changes your outlook and your approach to the patients. You know, it was 2 decades ago, and I remember it. And there have been situations like that, but this is, you know, when you say what 6 minutes change your approach to patients or your life, I can tell you, that's that time, that simple conversation, it's just a wake-up call on how you approach patients.
I'm certain that your heart was in the right place when you said that to him, that you were going to do everything in your power to save him, and that you truly thought you probably could save him, and you expected to save him. But sometimes things are a little out of your control, right? Sometimes
that is true. And that's the difference between somebody who practices a certain skill set that they have acquired and knowledge, and a real doctor. And that was a major, I tell you, turning point on how I approach patients, because I approach patients as a practitioner, as a technician. Here's what I'm going to do to you, and I'm going to fix you. Your plumbing is not correct over here. We can take care of that. There's a patient attached to that.
Yep. And so, just to you've had a lot of positive outcomes that are out there since. And I think that this award proves how much you've learned, over the last, couple of decades. And so I would love to hear a story about a patient who sticks with you in terms of their life being significantly impacted by your innovative treatment approach for PAD, and maybe what you had learned from that patient a couple decades ago.
Well, sure. I mean, sharing a story about a patient that impacted their life is a better question for the patient than for me. We all strive to positively impact the life of our patients, but it would be quite presumptive of me to assume that I do that, all the time. But I can actually share a short story of a patient that actually came to us through you and your website. You're the one who called me on the patient and said, "Here's a patient that is about to lose his leg, and he's been told that he has no other option." And we brought that patient in, and the patient had had multiple treatments and had, in my opinion, unnecessarily gotten to the point that he was when I saw him, and his toes were black. And many patients, when it gets to that stage and they have that degree of pain and they look at their foot and what they see, they give up. And if somebody says we have to amputate you, they go along. And amputation is the appropriate treatment in many patients, but not necessarily all. And so first we had to undo a lot of the things that had been done, and then get the blood flow going back and put the patient under intensive wound care and try to address all the other issues that go along with preservation of limb, which is not just fixing the circulation. And 2 years later, the patient still has his foot and is active. And I've seen him in follow-up, and it's interesting how close to losing his leg he was, that even when I first saw him, as you may recall, I dropped you a note and I said, "I'm not sure if this is going to work, but we're going to give it a try here." And I'm glad we did. He still has his leg, and he's has a reasonable quality of life.
And that's what I've appreciated so much about you, is that you're always willing to try, not in a way that if there is something that could hurt the patient, but you always know, and we have even a patient right now that has needed amputation, and another one that will need amputation anyway. I mean, sometimes, it is actually inevitable, and the patient does get to you too late, which is why today, being the start of PAD Awareness Month, it's a really important month to get the word out to the more than 70% of Americans that don't even know what PAD is, and even the primary care physicians who end up missing the textbook symptoms of intermittent claudication. You walk, you get a cramp, you rest, and the cramp eases. And if we would catch people then, especially those that have the high risk factors of diabetes, former smoker, current smoker, someone who's sedentary, someone with even coronary artery disease, high blood pressure, high cholesterol, we can catch those soonest. Then walking in and medicine are the best conservative treatment approaches to slow down the progression and even stall progression of peripheral artery disease. But what we're talking about are these patients that are arriving to you in the most advanced stages. And every single one of the patients I've sent you has been in advanced stage CLI and has already been told, in just about every case, I think, that an amputation is in fact in order, and you've been able to do so much and at least give it that last Hail Mary try for these patients, which I think is so important. We did have one, and this one was really the start of our relationship. You didn't really know me well, and it didn't have necessarily a general positive outcome. And I think that you understand as well as I do, it had the best outcome for this patient in this situation. because she did end up passing away. But because you were able to at least honor the family to get her out of and be the receiver of a transfer for her to your hospital with the promise that you would at least try to save her leg or do something, and so that she could pass in dignity. All the family wanted was to get her out of the other facility, which had this shared decision-making experience in which the cardiologist had told me that she didn't think this patient could survive an amputation, but yet she was going along with the team to perform an amputation on this patient, which struck me. And that's when you came in and said, you know what, let me just get her over here. And the family, all they wanted was for her to die in peace at a hospital where she felt respected, where she could die in dignity. And you allowed that opportunity. And for that, I will forever be grateful to you. And so will that family. And so you gave them a little bit of hope, not false hope, but a lot of respect and honor for their family. So again, you remember that case, and thank you from the bottom of my heart. And I was talking to the son, and he still appreciates you to this day for helping to get her out of that hospital and at least in some loving arms, in their opinion. So we appreciate it.
I appreciate the opportunity.
Yeah, this is just your personality. You just care so much about the patient. So really, what drives this? I mean, your passion is so evident. Why are you so passionate about reducing amputations and, going that extra mile to make a difference for these patients?
Oh, that's an easy answer. It's without a doubt the pride I take in my work. The satisfaction of successful outcome and the pain and misery of failure definitely is what drives my dedication to push the envelope. It is without a doubt the pride I take in my work.
I mean, just describe how you incorporate, and I think I gave a good example, but how do you incorporate empathy? And this is really important, I think, for every teacher. How do you incorporate empathy into your practice? And can you recall a moment where this approach really made a profound impact that you could see on a patient's experience?
I think some of the staff that work with me may chuckle at that question or my answer. And the reason is that I have a very dispassionate demeanor at work, which may be misinterpreted as lack of sympathy, but empathy is different. You have to assume that the person you're working on or treating is a member of your family. How would you treat, or what would you do if this person was your sibling, your mother, your father, your children? That's where the empathy comes from, and the fact that I may not show much emotion when I see patients or during work or when I work on patients, but that doesn't mean that in the back of my mind it's not that what is the best thing to do? What would I do with my own mother in this patient? The early on in medical school, when I first had clinical experience, the first patient I was assigned to work up had alcoholic liver disease. And when I approached the patient to interview, after the interview, history, physical, and all of that, my attending who was observing me came back and said that, I must sort of tell you that you were very non-judgmental in the room, and when you were asking questions, and that's the way to approach these patients. And that became a lesson, and that's, I think, this dispassionate sort of demeanor comes from. I don't mean not to be emotional, but it's just the way it is. And it's frequently it's just smaller things that we do that patients appreciate more. For example, there was a patient that I had worked on for hours and hours and hours. When patients we work on them, they may be under anesthesia or they're sedated. They don't see the hard work that you put into get the circulation going. But then afterwards, in the follow-up, it took 2, 3, 4 minutes to talk about, better dietary habits, better lifestyle, do this, do that. Look what I do. At my age, I still try to climb the mountains. And I got letters of appreciation from this patient, mostly regarding the fact that I spent a couple of minutes just to talk about dietary habits, not the hours that I had spent on trying to save the leg. And that we all need to be, very sensitive to, that it's a holistic approach to these patients that frequently matter. It's a talk you have with them before or after. I must confess that my level of empathy tends to increase with complexity of the clinical problem. And that's, it's a weakness. But that's, this interview is becoming quickly therapeutic for me.
Yeah. I mean, and I think that this is an example. In my introduction, I talked about you have the ability to do it right the first time, right? And you're always focused on the long-term outcome of the patient. And I think that what you just talked about really demonstrates exactly what I was talking about in spending so much time with the patient. Yes, you spent a lot of time with them, where they didn't realize it, and you were trying to, get their arteries open, which is sometimes hour after hour under, X-ray, putting your life at risk, to save their limb. But spending so much time talking about diet, which is such a critical risk factor that has to be mitigated, and so many aren't able to do it because no one takes the time to teach them like you did. And so that's pretty amazing. But I want you to also go into, one of the most, you said you like challenging, complex cases. Those are your weak points. You love them. Because, you're kind of like MacGyver. You like to go in and reverse engineer, that blood flow, the wellness of the patient's desire. And when other people say it can't be done, you're like, those are the ones you like to do and actually get done and save the patient's limb. But sometimes, you can't always do it alone. So I'm really curious, because one of the things that everyone is focusing on is really, interdisciplinary collaboration. And was there a particular case that stands out in which it took an interdisciplinary, approach, multiple practices coming together in order to get a patient back on their feet and stay on their feet, you'd like to share?
An interdisciplinary approach to these patients, these complex patients, is almost a day, weekly, if not a daily occurrence. I practice in a multi-specialty office anyway. They have some great vascular surgeons who are my partners, and we all practice together. But you cannot address complex clinical scenarios in isolation. That's a recipe for failure, especially in this patient population, that there's so many factors that go into that healing response and that health and prevention of amputation. Like, are they in heart failure? Are they on the right treatment? Do they have a good lifestyle? Is their diabetes under control? Is the hypertension under control? Are they getting and receiving good wound care? All of these need to be coordinated and have to happen at the same time. And by definition, this patient population needs that multi-specialty care. And sometimes that's not lacking, and that is lacking in the patients that come to us, and we refer them to the right specialist, starting with wound care, to see these patients, and we all work together. That has to be the case in the care of this particular group of patients.
So, in your opinion, what are the most advanced technologies, new innovation in PAD care, in any aspect of their care?
So as we talked about, the treatment of PAD is multi-pronged approach, multifactorial. So there are advances in wound care, there are advances in treatment of heart failure, hypertension, diabetes, all of those. The part that we focus on in our practice is what we call revascularization, which means just fixing the circulation. And there's certainly that sector in that area has seen significant treatments recently, significant advancements recently. For years and years and years, peripheral arterial disease took a backstage to coronary artery disease, and all the focus and the investment and the research that was going into coronary artery disease, which is now quite advanced. Some of that is percolating down into the treatment of patients with CLTI or CLI, which are quite challenging. Now, the use of bioabsorbable drug-eluting stents, adventitial multi-drug treatment, therapeutic ultrasound, deep venous arterialization. These are all new areas that some are in trials, some have completed studies that would add to the tools in the toolbox to treat this complex patient population.
Yeah, and one potential study that I hear you may be getting involved with is in regards to a potential retractable stent that we could be seeing sometime in maybe 2025, 26. I think it's already received CE mark in.
Yeah, that's another technology that is quite promising, and the drug-eluting version of that device and instrumentation is going into trials now. And the idea is to treat these patients and the circulation without leaving metallic devices behind that many of us don't like. Now, sometimes it's necessary, we have to do that, but generally we don't want to close the door to future treatments. And there are some creative, innovative approaches to that strategy and that way of thinking, and one of them is the technology you referred to. And we look forward to seeing the results of that study and starting the next phase of that trial.
We had the opportunity, it's actually Reflow Medical. I had the opportunity to go out down and tour their facility on Thursday and actually see how it works. And the number one thing that came to mind with that technology that I think is going to be game changing is, well, there are a couple things. One, below the knee treatment, number one. But number two is the gripe by many vascular surgeons that there are still a lot of doctors that don't consider a potential landing zone and screw up the landing zone when they're treating in a minimally invasive way and putting a full metal jacket on these patients from groin to toe, which says, okay, well, once those things get blocked, you can't get through them. What are you going to do? Because the landing zone, for patients that don't know, it's where a graft for a potential bypass would be reattached. And if you have a bunch of stents, where are you going to reattach a vessel, a graft? And so I think that this could be huge for that, because then you're not, and the one thing I always tell my patients as well is, you want to make sure that whatever procedure you're having, there always needs to be a contingency plan. When that flight fails, what's next? And if minimally invasive fails, well, then it fails multiple times, and there's no other option that way. You need to make sure that you can potentially have bypass afterwards, right? And this device, increases the chance that it leaves open more options for these patients.
Absolutely, and that's why it's promising, and we look forward to it. And I think it would be an advancement in the care of this patient population.
So is there any frustrating part about this whole process and where we're at right now with the treatment of PAD that, if we don't fix this problem, that it's going to have terrible consequences? Something that you fear right now?
So what frustrates me or discourages me, is that what you're asking?
It seems like you have an idea of how you want to address that. Go ahead and take it with what's in your heart.
Yeah, I tell you, there. Let me separate that. You know what frustrates me is the behavior of policymakers, the insurance companies, the payers, uh, at top of which is the Center for Medicare and Medicaid, CMS, that their payment policies is not evidence-based. And then the hospitals. Now, I understand the position of the hospitals that they don't always equip and provide the equipment for treating physician that we need due to financial considerations. I get it. They need to be, they need to be financially viable. Cost effectiveness aside, the whole approach of policymakers and the providers, which would be hospitals or the facilities, to this approach is quite frustrating. Now, we do practice in a market economy, so some of this comes with the territory. It's not that the Canadian model or the European models are any better. They have their own challenges and issues, and this will always be one of ours. But this needs more attention, and that is quite frustrating to me. What is discouraging sometimes is completely different. And sometimes my inability to engage patients to take charge of their own health and be responsible for their own health. We're just part of the team. We are, they can't just hand their health to the doctor and say, you take care of it. They have to be an integral part of it. And relaying that message sometimes is quite discouraging because some just don't take care of themselves, for lack of a better word, despite all our efforts to the contrary. And that's sometimes discouraging. And it is our fault that we have not found a good way to engage them and the right triggers in those patients to motivate them. And that's sometimes discouraging.
That's one thing that we talk about all the time in our group is how do you become a better partner in your care? The doctors can only do so much. They are your partner, but you're their partner in care. And so once they go and they open up those arteries, if they have to go in and open those arteries, then it's up to you at that point to maintain those vessels open by doing your part, walking this medicine, pushing through that cramping, eating them, taking your medications as scheduled, stopping smoking or vaping or whatever it might be. And that is so important. And that's something that we at the Global PAD Association, we're trying to be better partners for all of you physicians and clinicians that are literally putting your life on the line, everybody else's limbs. And, we want to make sure that we can help these patients be better partners.
Absolutely, Kim, I must say that, to do this effectively is probably one of the most difficult tasks in the care pathway of these patients. One generally has to focus on what motivates a particular patient. Unfortunately, the fear of losing one's leg can be a fleeting emotion. And the messaging has to be recurring but not repetitive. And this is where resources like your website and what you guys are doing is critical. That since I have become familiar with what you guys do and you have educated me with the resources available on your website, I refer our patients to your website. And that is affirmative of what we have done. We can bring these patients back every week to reassure them and repeat our message. This patient population don't want to be in doctor's office all the time. The quality of life matters, but that's where you guys come in and where your resources can help these patients do that on their own at home and reinforce what we have talked about.
Yes, thank you so much. We need to get your team on a walking program for all your patients as well.
Absolutely. Absolutely.
I have just a few more questions for you, and I know that our studio audience has a couple as well. We have several series that we do, and so one of them is our Journey to Diagnosis series. So, share a case that had you, just scratching your head about how in the world did this patient not get diagnosed sooner, and what would you have wished would have happened differently with that patient? I mean, you could even share a story whom you couldn't believe that other procedures, such as even a spinal fusion, were done when they should have actually been diagnosed with PAD.
You know, if that wasn't sad, it would be comical. I can tell you the stories that one could share of the patients that come in that people have gone completely in a different direction. Now, I must say that when patients come to their primary care physician or internist office, in this patient population have multiple problems. They have heart disease, they have kidney disease, they have hypertension, they have diabetes, and physicians and their primary care physicians have so many other things that they have to deal with these patients. So it is not surprising that they may not examine the foot or look at the foot or examine the pulses, which frequently happens. And that's where patient responsibility comes in, that they have to bring that up to their doctor. If there's something, living with pain is not necessarily part of getting old. That is not the case. They have to search for the reasons and they have to bring it up to their doctors. If their toes are not feeling well, or they're turning black or become painful, they need to bring it to the attention of their doctor so their doctors can make the correct referrals. But I tell you, even in those situations, there have been some major mishaps. There's a recent case of ours that the patient came to us with multiple procedures performed elsewhere. You brought up the issue of a spinal fusion. And I can tell you that some get interventions on their veins, some get on the wrong medications, some are treated with just pain medication, while it's a simple circulation issue, arterial issue that one can take care of. But we're thankful that the awareness among patients and physicians is increasing thanks to efforts of people like you.
We're working on it. It's just, trying to do what the Susan G. Komen Foundation did, which is to lead with patients and create an uprising, right? And I think that that's really important. One more from me. This is another one of our series, and it is, physicians helping with other physicians to learn a lesson through your experience. So share a case with a big lesson for you and others. Describe the patient, the frustration with the case, and the lesson you learned and that others can learn. And it could be a success, it could be a failure, it could include, a little bit of ingenuity that you demonstrated. But this one starts with, I'm Dr. Mahmoud Razave, and here's an important case which came with a powerful lesson.
I'll tell you, the lesson there is not from me to somebody else, it's from somebody else to me. When I was younger in my career, and I was, my senior partner is a guy by the name of Michael Dake, who's one of the pioneers in the minimally invasive treatment of aortic disease. And I was trying to treat a patient with peripheral arterial disease who had just a narrowing stenosis, calcified and tortuous vessel. And I was struggling to get through. And he walked in the room and he said, Mahmoud, if the contrast and the dye gets through that stenosis, so can you. And then he continued by saying that if there's complete blockage, you know that there was a structure there, and it's still there. You just have to find it. I can't tell you how that little message changed my mindset and approach to these patients. That, okay, if there's a structure there, it was there before, it's not there now, but it was there before, there's a path, you just have to find it. But if the dye gets through it, so can you. And that really changed my approach and the success rate. I can't tell you how much more successful I became after that simple, lesson by my senior to me, in terms of, and it just had to do with your confidence level and your mindset. It's a mindset that's very important when you approach these patients, like any athlete. If you go in with the expectations to win, more than likely you're going to win. And that was the case. And it reinforces the old adage that every patient is a laboratory, that if you are not successful, obviously these lessons learned should help you on the next patient. And that mentality obviously needs to be there for one to be successful.
Wow, that was really powerful. I always tell my patients that in my travels around the world since 2016, hundreds of doctors, thousands of hours of procedures spent, in the cath lab alongside them, learning and growing with them. The one thing that stood out with CLI fighters such as yourself, and I haven't found one CLI fighter that hasn't maintained this philosophy, but expressed in different ways, is that I see my patients in their wellness, and I am the facilitator of that wellness in which I see in them, and I just reverse engineer it to provide that wellness that they desire. And it reminds me, and whether you're religious or not, or which source you believe, but there have been multiple evangelists that have been out there, and healers supposedly, and they would tell you that it's not necessarily them healing, it's they're just literally facilitating the wellness of that patient desires, right? And I see you nodding, so you definitely agree with.
Absolutely. We're just facilitators of their health. We have to give patients. Now, sometimes that facilitation means you have to do procedures and all that on patients, but you have to empower patients to heal themselves.
So I want to open it up. We only have a few more minutes here, but I could talk to you forever. This has been incredible. Douglas has a question. Douglas, go ahead and unmute and ask Dr. Mahmoud Rezaveh, our USA Interventional Radiologist of the Year.
So my first thought, how do we bottle that up that you have so we can send that out across the universe and make those changes? That spirit that you put out there right now is just, how do we bottle that and send that out there? It would be awesome if we could figure a way to do that. Thank you for what you do and being the CLI fighter that you are. But I guess this might be a tough question, but why is it so hard for like vascular surgeons to understand what you do and to try the things that you do? Why is there such a vast difference between the two of them?
Let me take the last point first. The vascular surgery community is obviously, many of them do what we do. And many of them are partners in creation. The distinction between a vascular surgeon, radiologist, cardiologist in this field are going away, and appropriately so. We're all part of the same team taking care of the patients. Now, it also has to do with people's experiences and their expertise. If somebody is good at bypass, that's all they want to do. And I don't know how to do a bypass. Therefore, if you come to me, you're not going to get a bypass. But at some point, one would recognize that bypass is the way to go, or amputation is the way to go. And that's all part of that multi-specialty approach and multiple partners in treating the same disease. So I'm not sure if it would be unfair to the vascular surgery community to say that they don't do it. They do, and they're coming along. But it's a highly individual thing. The other point you brought up is just that's a billion-dollar question. How do we propagate the messaging and the information? And that's where you guys come in. We can only do so much, and we can participate in that process and be your partners to get the word out. And I can tell you, just in my experience, PAD went from a not known, unknown disease to what it is now, that it is becoming more and more recognized. As I mentioned, PAD was the bastard child of coronary artery disease, not any longer. And that is due to a lot of times efforts of people like Kim.
Yeah, but so some vascular surgeons seem to not want to do any other practice with PAD. Maybe Kim, you know what I'm trying?
Yeah, wow, he's asking some loaded questions here.
I know. I'm sorry.
There were some articles that were shared in the group and such, and so there was a conversation that transpired, Dr. Rosado, recently, with some concern where it seemed that you saw the New York Times article. Well, there was some response by a couple of societies that seem to allude to the fact that vascular surgeons should be the only ones treating PAD. And he's wondering, and this was the conversation that kind of transpired between patients, is I don't understand why there's such this turf war when there's so many people doing so much good, practice aside. Why can't everyone just collaborate for the sake of the patient? Is that what you're trying to say?
Yeah, because there's how many patients out here are we? I mean, I'm pretty sure there's enough to go around for everybody.
Yeah, the first of all, that New York Times article was a pure character assassination of one of the people who most dedicated to this space. But that's something different. But the issue of who should take care of these patients, I think, in my opinion, anybody who's good at it, and anybody who has a passion for it, and anybody who can take it on, regardless of what your background is and what your specialty is. I mean, look at me. Yeah, I came from an imaging background, and here I am treating vascular disease, talking to patients about hypertension control and diet. But that's just become part of my skill set. And that's where empowering patients to seek second opinions come from. Don't be shy of asking difficult questions of your doctor. How many have you done? What's your approach to this? Can I, I want to get a second opinion regarding whatever recommendation that is. A good, confident doctor will not get threatened nor insulted by that, and patients should do that and should ask that. And I second what you said, Kim, that the treatment of this patient population should not follow political lines of various specialists and specialties. We're above that.
Yeah, I think so, especially when I have so many patients across the country that they don't have access. I have, let's say in Central Valley, California, I have one vascular surgeon, poor guy, ends up on call having to manage 3 different hospitals, 2 hours, each one of them 2 hours apart. And it's just like, he says, hey, I don't even spend enough time with my family. I'm constantly running from one to another, to another, to another. So there really aren't enough vascular surgeons to go around, and we do need more. So anyone who wants to go to medical school, we do need more, but we need more doctors in multiple practices who are interested in the advanced treatment of CLI, because with diabetes being out of control, and I think the ADA had come out in the past year saying that more than 50% of American adults alone have either pre-diabetes or are type 2 diabetic or type 1. And so this is a real serious problem. And even the American Diabetes Association recognizes this is a big problem. And they formed the PAD Alliance. And one of our board members, Dr. David Alper, is an advisor to the PAD Alliance. And the American Diabetes Association on that page has 2 resources that they send patients to for help. One of them is the Global PAD Association's Lifesaver Hotline, and the other one is our Find a Doctor page. And so it really just drives home the point that everyone sees this as a really huge problem, and we need more practitioners to be focusing on this. You know, I pray that we don't need more, you know, surgeons and interventionalists, but we do, because a lot of these patients, right, Dr. Razave, they're
Right.
asymptomatic to a point where they're a toe stub away from amputation, because most of their symptoms are brushed off as diabetic neuropathy, and it's really tough to tell unless they get the test.
Absolutely correct. And the you know the efforts and the battle continues.
We just have two more questions, it looks like. I think Marcia has a question. Marcia, go ahead and unmute.
Yes, thank you, doctor, and congratulations on your award. Well deserved, I can tell. I really didn't have a question. I was just going to say that knowing that you remembered that letter, and you know you have lots and lots of patients, it really struck me that you know our doctors are human, and you know who doesn't like a good pat on the back, and to know that you made a difference. And so it has kind of inspired me to maybe write my doctor personally. So I just wanted to thank you, and thank you for the investment you give to your patients.
Oh, absolutely, and I'm sure your doctor would appreciate it. And it's good to know, you know, every once in a while that you know, one has done a good job.
Yeah. And one more from I think Marcia Burr also has. We've got double Marcias here today. Marcia Burr, I think, has a question as well.
Yes, good afternoon, doctor. Thank you for sharing time with us on September 1st, the beginning of International PAD Awareness Month. And thank you so much for caring. I have two questions, and they're both kind of loaded. What hurdles have you overcome in interdisciplinary collaboration? And what do you see as the greatest lessons you've learned?
So Marcia, thank you for your questions, and thank you for participating and being a participant in the awareness and this International Month of PAD awareness. So the multi-specialty approach to any patients, you know, cancer patients, PAD patients, heart failure patients, can be challenging. And what happens over time is that we learn by trial and error as to who our partners are in this effort. There are a lot of wound care specialists, you know, in any one community. We're fortunate to have many. Some communities have none. And then you have to partner and recognize with cardiologists, with endocrinologists to manage diabetes, with podiatrists to manage the patient's wound and wound care and take care of the patient's feet. And over time, you learn. And we have certainly had people over the years that we thought maybe reliable partners in this effort turned out not to be the case, and we just move on. Again, we are fortunate in our community to have access to multiple, and it has gotten to a point that is now, for lack of better word, an assembly line. That we know where to send the patients for wound care. We know if they're, for example, A1C is not under control, message their primary care physician, see if they need help with an endocrinologist. If they don't have a good podiatrist, send them to a good podiatrist. And the lesson in there is that the lesson we've learned, at least in our practice, to make sure that you have the right partners. It's like any other partnership. that you have to have the right members of the team. It's a teamwork. It's a basketball, football, soccer. If one piece is missing, you're not going to be successful. So the lesson for us has been to make sure that that team is the right team when you go and take care of these patients.
Yes, thank you. I think also that the team includes the patient themselves.
Oh, absolutely. That's
Very
number one. That's
and
number one.
very knowledgeable.
Remember, and the message to all the patients that the patients are the captain of the team. You have to drive that. You can't relinquish that responsibility to someone else.
Yep. Thank you, Dr. Rezave. This has been incredible. I appreciate you so much. This is a holiday weekend too. It just again further demonstrates your commitment to patients, their care, improving awareness. You're amazing, and it's so well deserved. Our USA Interventional Radiologist of the Year, Dr. Mahmoud Rezave. Thank you.
Thank you. Thank you.